Hi, everyone. My name is Sheila Davis, and I'm the CEO of Partners in Health. And thanks so much for joining us tonight. We're so excited to all gather together to talk about some really important topics. Before we start, for Zoom control, just want to give you a few tidbits. At the top of your screen, we recommend that you adjust to the side-by-side view, and then you'll be able to see the person who is speaking, and then also some of our other colleagues who are going to be answering some of the questions. And you can also toggle back and forth to best figure out the best view for you. This is such an important topic. We're going to be talking about maternal and child health, and this is so critical, certainly for all of us, and is the foundation of Partners in Health's care around the world. 2/3 of our care delivery is focused on women and children. And we deliver many, many babies throughout the world, do C-sections, take care of many, many children with immunizations and primary care. And it's a core part of what we do, since it's a core part of our communities. Sadly, maternal mortality is still a huge issue, and more than 800 women around the world die every day due to complications of pregnancy. This is really unacceptable, and something that we as a global community have to join together and combat, because it really is something that is really points to a report card on our health system, is how our maternal care is being delivered. We know that Partners in Health for over 30 years has been instrumental in addressing health inequities, and really maternal care is the core part of a lot of what we do, and really excited to talk to all of you today. We're going to be joined by amazing Sierra Leonean colleagues to be able to answer some of the questions and talk about a really exciting endeavor that we have happening in Sierra Leone. Partners in Health first went into Sierra Leone in 2014 in response to the Ebola outbreak. And we didn't go there we're not necessarily an emergency organization, although we deal with emergencies in 11 countries in which we work around the world. But Ebola was a symptom of a broken health system. So when we went in to combat Ebola, we knew we would stay long-term, partner with our Sierra Leone government and Ministry of Health colleagues, and make a long-term commitment to really changing and improving the health system there. We've continued to be there since 2014 and continue to learn a tremendous amount from our Sierra Leone colleagues, and really excited about all the improvements and advances of what's happened so far. We also have a long ways to go, and that's what we look forward to talking about tonight, and hearing about some exciting endeavors we can move forward on. The Maternal Center of Excellence is something you'll hear about, and that's a project that has been in planning for a few years. And although we're already making massive strides in improving health outcomes for women and children, we need a better facility. We need a better place to be able to care for and train many, many people who we need to be able to combat maternal mortality and take care of women and children. We're really excited and so thankful that all of you are here, and many of you have given us generous support to support the Maternal Center of Excellence, as well as our care around the world, and we really appreciate that. One of the things I'm very excited about tonight is we're joined by a very generous supporter, Jourdan McGinn, and also his other family members, his wife Sarah and Hank and others, who really have made a commitment to Partners in Health and a commitment to the people of Sierra Leone to try to improve maternal health and try to improve overall the health system. You may know Jourdan McGinn's name. He's a New York Times bestseller author, YouTube content creator, philanthropist, and just overall a really, really good guy, and really excited that he's joining us today. So look forward to all of your questions at the end, and go ahead, Jourdan.
Hi, hello. Thank you, Sheila, for that lovely introduction, and thanks to all of you for being here tonight. I'm just going to talk a little bit about how my family and I came to be involved with Partners in Health before we get to dive into a conversation, really exciting conversation about the future of a better healthcare system to serve the people in Kono district in Sierra Leone and beyond. So I am a YouTuber and a novelist, but I am also the child of two people whose professional lives have been devoted to making a better world. My mom, whose work as a community activist inspired me from childhood and inspires me still, and my dad, whose work in land conservation and environmental causes stretches back more than 4 decades. They are here with us tonight, and I want to begin by saying thank you to them for teaching us so much about how we should live our lives and how we could be better advocates for social justice. And most of all, for supporting our work with Partners in Health and in joining us as donors. So my brother Hank and I have been giving to PIH through various projects for over 10 years, but initially we mostly focused on like responses to crises that made headlines, you know, like earthquake relief efforts or responses to disease outbreaks. And that work is critical, of course, but as we began to learn more from PIH and from people living in the communities where they work, we saw how often resources flood in when a crisis is making headlines and then disappear when global attention moves elsewhere, often without strengthening the healthcare system in a lasting way. Like in 2014, we watched as aid money poured into Sierra Leone to confront the Ebola crisis and also into Liberia and Guinea. Now, Ebola is like ostensibly caused by a virus, but in point of fact, it is functionally caused by poverty and insufficiently supported healthcare systems. And like so many forms of injustice, it becomes a vicious cycle. Ebola spreads efficiently in places with fragile healthcare systems, and the ravages of the disease further weaken those healthcare systems. Infectious disease does not treat people equally unless our social orders treat people equally. That's something we're seeing around the world right now with COVID-19, but also with lots of other infectious diseases, from HIV to tuberculosis. And so when the world moved on from Ebola response, despite all the short-term investment, the Sierra Leonean healthcare system had only grown weaker as a result of the disease's devastations, and the ongoing crisis of maternal mortality in Sierra Leone had only worsened. And what I came to understand from learning from some of the people we're going to learn from tonight is that maternal and child mortality in Sierra Leone are emergencies. They are crises. They're just emergencies that don't make headlines. So as our family began to learn more about the context of these crises and the reasons why countries like Sierra Leone have fragile and impoverished healthcare systems, we came to believe that, to borrow a phrase from Ophelia Dahl, long-term systemic problems demand long-term systemic solutions. Around the same time, my brother and I had become financially successful in ways that we had never anticipated. And we knew we wanted to give back to help create a more just and equitable social order. But at the time, we didn't really know how to do that. And we were like a little bit paralyzed, I think, by the sheer number of problems in the world. So we were mostly focused on trying to grow a charitable foundation to become like the biggest possible size it could be, so that it could grow and get bigger and bigger and generate lots of revenue in the future. This is basically like what we had been told about investments, that you like invest money in the stock market or whatever, and then the money grows, and then you can do more good with it once the pile of money gets big enough, I guess. But what I came to believe is that if we gave away the money immediately, it would also grow. It just wouldn't grow under our control. It would grow in the form of better maternal and neonatal care, and it would grow in the form of more healthcare workers to offer a preferential treatment option for the poor, and it would grow in the form of fewer kids suffering from malnutrition, more kids having educational opportunities, and so on. And that growth could be felt not just through the years, but through the generations. It seemed to me that the need was immediate. And so we decided that our response should be immediate too. And after seeing the transformative work that PIH Sierra Leone is doing and listening to many of the people that we get to listen to here tonight, our family decided to make a long-term open-ended commitment to supporting PIH Sierra Leone in their efforts to strengthen the healthcare system in what is currently among the epicenters of maternal and child mortality. We really hope that this project can be a blueprint for other communities, showing that we just do not have to accept a world where so many women living in impoverished communities experience pregnancy as a life-threatening condition. We do not need to accept a world where so many women die in childbirth and so many children die in the first 5 years of life. So tonight we're joined by some really extraordinary people who are bending the arc of the universe toward justice. And we're going to get to learn about some of the challenges Sierra Leonean healthcare workers face, but also about the progress that is being made and about the big next steps that are coming. So our guests tonight are Dr. Joia Mukherjee, who is PIH's Chief Medical Officer, Isata Dumbuya, a nurse midwife who leads the Reproductive, Maternal, and Child Health Program for PIH Sierra Leone. And we're joined by Jourdan McGinn, the Deputy Executive Director of PIH Sierra Leone, and by Armah Quist, who is a Program Officer with PIH Sierra Leone at the Lakka Government Hospital. I should say before I start talking to these wonderful people that you should feel free to leave questions in the comments section throughout the conversation. We'll try to answer as many of them as possible toward the end, but we will probably wait to the end. So you have as long as you would like to ask your questions. I'm going to begin, if that's okay, with Dr. Mukherjee. Are you there, Joia?
Yes, I am.
Hi.
I'm here. Hi.
How's it going? I can't see you. I will feel personally better.
I can see you.
Now, I can see you now, and it makes me feel much better.
Yeah. Yeah.
So you, given your many years of work with PIH, I wonder if you could share some of your own personal experiences while working in maternal health, which is something I know that you've done for a long time, and what PIH has learned from working in the field of maternal health as well.
Yeah. Thanks, John. And thanks to you and Sarah and Hank and your family for all your support and for highlighting these problems, as you say, these things that are daily emergencies. I mean, imagine what it's like to face childbirth thinking that you might die. And there are poems from the turn of the 19th century. In fact, my clinical home is the Brigham and Women's Hospital, which was established at the turn of the 19th century so that women could come, and it was called the lying in hospital, wait in labor so they could have a safe delivery, because back in the horse and buggy days in Boston, it was too dangerous to just wait at home and if there was an emergency. But that is not a new technology, lying in, waiting. These are technologies that are more than a century old. And when I first started to work overseas in Africa, I was surprised to see that for women who were pregnant, there was no really advanced care. And by advanced care, I mean even just delivering at a facility that's clean. And in fact, most community programs would just teach village women who are considered traditional midwives to deliver safely on the floor of a hut, and hand out razor blades so that they could cut the cord, teach these women how to boil the razor blades to sterilize them. And I was actually frankly appalled. I didn't understand that in the 20th century that was what passed as a maternal health program. And for 40 years, billions of dollars were spent in public health, training these traditional midwives to do these things in, the hut of a dirt floor, when what women die of, if they die in childbirth, is hemorrhage, obstruction, they can't get the baby out, they need a C-section, or very severe infection and they need antibiotics. And so, to me, understanding that this was normal care, we're not talking state of the art, we're not talking sophisticated care. In fact, Cesarean section is probably the most life-saving operation that was ever, used, and it goes back to the time of Caesar. So these are not new technologies, but no one was trying. And so for me, I remember being with a woman and a traditional midwife in Kenya before I started at PIH, and this traditional midwife trying desperately to get the baby out, completely breech birth. There was no chance that the mom would go to the hospital. There was no operating room that could take her. She had no money, and she and the baby died. And I was just broken by that experience. And, I continued to work in Africa and then joined PIH. And part of what made me fall in love with Partners in Health was the fact that no one thought that was normal, right? I was trained in public health to think, well, that's the best we can do, but it's not the best we can do. And so I think my passion was so well aligned with the midwives in Haiti and around the world, and people like Isata and Armah and others, to say women deserve the standard of care the same anywhere, whether they're in the United States, in Sierra Leone, in Haiti, whether they're in a city like Trenton, New Jersey, or in my city of Brookline, Massachusetts. And we know that these disparities between who lives and who dies when women are pregnant are definitely very strongly influenced by the structures that are influenced by racism, by impoverishment, and by policies that really just assume that some people's lives are not worth that much. So we have long looked at maternal mortality, as Sheila says, as a report card for the health system, meaning that you can't just do one thing. You can't press here and fix it. You have to have good community care. People who are working in the community with these traditional midwives identify women early in their pregnancy so they can get the care they need, the prenatal care, modern prenatal care, AIDS testing, antibiotics if they need it, blood pressure control. Then you need good primary care so that every antenatal care has simple things like a blood pressure cuff that works. You would be amazed at the things that count as antenatal care that are not any kind of care. And then the third element you really need is what we call emergency obstetrical care. And that is the most life-saving piece for mothers. And that is C-section, blood, antibiotics. So you've got to build a system that has community care, primary health care, and hospital care. And that's why we say maternal mortality is a report card for the health system. You can frankly treat malaria and save lots of kids out of a backpack. You can have little rapid tests, you can give some pills for 3 days, and you can save their lives. And that's great. And we love those backpacks, but we can't assume that just because you're a poor African person, if it's not in a backpack, you can't get it. And so that's why we say that focusing on raising the level of maternity care is a way to implicate all the full system, from surgeons to midwives to community workers to the laboratory folks in the blood bank and beyond. So it is really a way to raise overall the standard of care. And, it needs electricity, running water, other operational infrastructure that many hospitals in poor communities have and you don't have. And when we tie this back to how we think about the US, while it's hard for many of us to imagine thinking that we or our babies might die in childbirth, we know that these same issues are affecting women of color who, in the United States, Black women are 3 times more likely to die in childbirth than white women. And this highlights the role of impoverishment and racism on maternal mortality, and really convinces us all the more that this fundamental piece of healthcare must be a human right and implicates all of these levels of social justice.
Yeah, that's one of the things that you really helped me understand, is that this is a human rights issue and that it is an issue of structural injustice with a very long with very deep historical roots and very profound historical roots, and it's impossible to understand contemporary impoverishment without understanding that historical context. I just want to go back briefly because I think it's so important to the difference between the interventions that seek to be simple solutions, especially simple solutions that you can explain to donors, if we're going to be frank about it, that distribute enough of these razor blades and we can save X number of lives. But when I first started talking, learning from you and your colleagues about the work that was being done in Sierra Leone around maternal mortality, what was explained to me is that it's not an issue of ambulances or blood pressure cuffs or medications or electricity or running water so that operating rooms can be clean and safe and sanitary. It's an issue of and that if the system does not get stronger, then there is no way to make lasting change. And that I think is really powerful. And I mean, it's expensive. I'm not going to pretend it's not expensive, but it's transformational.
Yeah. And I think, what we saw with Ebola and when you said, that I taught you that, I have to just for a second mention Paul Farmer's new book that came out today, Fevers, Feuds, and Diamonds, which is about the historical underpinnings of the Ebola epidemic. And Paul is certainly the person who taught me how important this is. None of these problems started today, and they're not going to be solved today. But if we really look at the history and invest in the places that were so historically impoverished, that's why I use the term impoverished instead of poor, because it's an extraction, and nowhere is that more clear than in Kono district in Sierra Leone, where the very hospital is literally in the shadow of a diamond mine, and the diamonds, all of the resources are being just sucked out of the community, and in fact attracted all kinds of untold horror. So read Paul's book, and I'm sure many of you will. And so as we started to look at Ebola, as John said, it wasn't a question only of a virus, right? I'm an infectious disease doctor. I went in the unit. Many of our great colleagues were, in their PPE in the unit, but we weren't the ones getting, occasionally a health worker got Ebola, but it was the people who were living 10, 12 people in a house, the people who didn't have the opportunity, the privilege to isolate and quarantine, the things that we're hearing now with Ebola that drives with COVID, that drives the inequality so high also in COVID. These things are what make people very susceptible. And then when you go to get care, there's no care for you. So the initial work in Ebola, trying to get people to go to the facilities weren't prepared, and then health workers would die. And then we would say, well, go to the holding centers, and the holding centers had no stuff, right? No food, no water, right? No proper protection for family members and no caregivers. So we started to treat Ebola, but we rapidly understood that Ebola was just one piece of the overall suffering of people we saw. One of the district directors said, I'm glad you're here helping us do Ebola, but if a kid falls out of a mango tree and breaks his arm, what am I going to do? Right? Mm-hmm. And Reagan Marsh, who I believe is probably on the call tonight, who was our chief medical officer in Sierra Leone for a number of years as we were setting up, wrote beautifully about during Ebola, in the middle of the crisis, a woman coming in, being bounced hither and yon because no facility had adequate supplies to take care of a pregnant woman, and she ended up dying. And that wasn't because of Ebola directly, but it was indirectly because of the impact of this terrible disease on a health system that was absolutely unprepared for that.
Yeah.
So we did see that, Sierra Leone had the highest maternal mortality in the world. And so that really became our focus, that if we could focus on maternal mortality, that would prepare the system for Ebola. That would prepare the system to fix that broken arm of that kid. And so really we look at it as a battle horse, that it will bring attention to this human rights issue and feminist issue, but at the very same time, elevate the standard of care.
Yeah. Yeah, as Dr. Barry said to me in Sierra Leone, that most of the people who died of Ebola didn't die of Ebola. They died because the healthcare system was under so much stress, and because care was so hard to come by. Maternal mortality increased by 22% during the Ebola outbreak in Sierra Leone, and so it's another example of when this what can happen when the system when no resources are put into strengthening the system. Well, I am going to move now, if I may, to
Yes.
Isata. Dr. Mukherjee, thanks as always for talking with me. We'll see you back for the Q&A.
Yep.
But we're also joined by Isata Dumbuya, who has been leading the maternity ward at the Well Body Clinic, which is supported by PIH, and also at the Koidu Government Hospital in Kono District since 2018. And Isata, I wonder if you could first tell us what inspired you personally to work in Sierra Leone.
Hi, John. So I was born in Kono District, and I grew up between Sierra Leone and the UK. So I spent quite a number of years in Sierra Leone, especially going to secondary school. So I know Sierra Leone and can feel the vibe of it. But in the UK, I trained to be a nurse and then a midwife. So I finished my midwifery training in 1999. And I remember throughout those years, sitting in school, and then we'll start talking about maternal mortality. And as soon as that conversation started, I remember cringing, because I know what's going to happen. The entire class will turn around to look at me, because Sierra Leone is going to feature in this. It's going to come out with the highest maternal mortality. And people look at you as if to say, what are you going to do about it? How and what's happening here? And you feel as if you have to have an answer. You have to say something, or you have to do something to address this. So in all my years of working as a midwife and a nurse in the UK, and also traveling around and volunteering in various other places, I saw one maternal death. One woman died. And this woman that died in the hospital I worked in on that night shift was actually from Sierra Leone. Wow. So this just really sort of resounded with me that, I have to do something. I'm in a safe place in the UK. I've got systems, I've got services, I've got resources, I've got everything I need to be able to make my job enjoyable and positive. And yet there are women and babies dying out there in Sierra Leone. And I felt as if I've got something to give towards this. I can do something towards this. I know midwifery, and I know that midwives are needed in Sierra Leone. So let's go see what we can do there.
And when you first came to Koidu Government Hospital, what was the situation there as compared to, say, the United Kingdom, or even what your expectations were?
So when I got there, it was a lot different from the United Kingdom. In the first week of arriving, 2 women died, and this was a shock. This was a real eye opener, because when you read about these figures, until you actually see someone, a live woman, she was pregnant. Where I come from, women do not die as a result of pregnancy. They do not die as a result of wanting to give birth. So you see these young women come in and in front of your eyes, and you see they die. They die from preventable things. They die from things that when I was training and working, I read about these things in textbooks. And when they do happen, the whole system comes together and we save these women, and they're okay, and their babies are okay, and they leave the hospital and they go home. Yet here, this was not happening. This was not happening. And over the years, it's taken us time to gradually start to try and change this picture. And it is changing. It has changed since I've been here. It's changed because we now have systems and services in place that do make a difference. What are these systems? We have a working blood bank. So women come in, and if they need blood, they're able to get safe blood that can be able to save their lives. We've got pharmacies and labs so that when we need to have results about what is happening with this woman, we can access it. We've got drugs that we can be able to give them to improve their conditions and improve their chances of survival. We have equipment and things, and we have well-motivated and trained staff. This is also one of the biggest differences that has changed over the last couple of years, because these staff, it's not that they weren't motivated before, but if you go and train someone and they come back and they don't have the resources, they don't have the wherewithal to be able to put that training to use, the results are going to be the same. They are going to leave feeling disappointed, but also helpless. What can I do? What can I do? She comes in. We could have saved her, but we can't because we don't have the equipment and the resources to do that. This is no longer the case. They go for training, they get mentorship on the ground, they get the resources to be able to put that training into use. They're able to stand there and work together as a team, as a well-unified team, that we're going to save this woman. We're going to throw everything at her to bring her back. We're going to throw everything at her to make a difference for herself, for her baby, for her family, so that we can save her. And when she dies, the ones that do still die, we are crushed and defeated by that, because we don't want these things to keep on happening. And these are usually still from preventable causes, from things that where you and I come from and live. Women do not die from these things. They really don't. We've got some really, really great results. We've done really well. We've got a high dependency unit, which is set up now to make sure that when sick women come in, we're able to treat them, we're able to care for them, and we're able to support them to recover better and faster. And the same for their babies, because we have a special care baby unit now that small premature babies, sick babies can get care from. We've got great results, as in our primary healthcare unit, which is Wellbody unit, that is run and supported by PIH, who's had no maternal deaths since 2016. There's nowhere else in Sierra Leone that can boast of that, including the hospital that we are in. But at the hospital, like Lakka Government Hospital, more women are coming. We've seen a 38% increase in uptake in antenatal care. So women feel safe about coming to us. Women want to come and seek care from us in our hospitals. We've also seen that the delivery rate has increased within there. So up to about 69% delivery rate has increased. So women coming in and having babies. So we're doing a great job, and we will continue to do that. But we need to do more, because there's still women out there that are dying. There's still women out there that are not accessing this service. There's still women out there that that for whatever reason do not come to us, and they still die, and they come in either dying or coming to us and die. And this hurts, this breaks us, because we feel that every woman has a right to live. It shouldn't be dying just because she wants to have a baby. This is not accepted in other parts of the world, and this is something that we all need to fight and push towards to start to eradicate within Sierra Leone.
Yeah, and when I talked to you recently and I asked you what you felt like was the next really important step, the next critical step, the thing that, you know, just couldn't wait, you immediately answered that the Maternal Center of Excellence is that for you. And I wonder if you can talk a little bit about why you see that as such an important next step and such a transformative moment for healthcare in Kono.
So, John, I said earlier that I took on this job to come and be a part of the maternal scene within Sierra Leone. One of the things that really caught my attention when I saw the job application was the Maternal Center of Excellence. Because then it was an outline saying that this is what we want to do and this is what we're working towards. And I felt that, wow, somebody cares enough to actually want to do this. Somebody has sat and thought this through, because within Maternal Center of Excellence, this is not just going to be it is a beautiful building, by the way, but this is not just the crux of it, because within there, you're talking about women who are able to come from within Sierra Leone and get comprehensive, holistic care. So this care would include not just maternity aspects of it. So we're talking about being able to offer cervical screening, oncology care. This doesn't happen here. There's a lot of cervical cancer and women die from this. This is an easily treatable and preventable thing. We don't do this here. this maternal center of excellence will be a place where women are going to be able to access that sort of care. Family planning, being able to offer a safe place for adolescents and youth-friendly services. We've already started doing that, but being within the maternal center of excellence, be able to offer all aspects of this on a wider basis, this is going to be fantastic, where women can come and get treatment, infertility treatment. Most women now try for years. Those who can afford it have to go to Ghana or Nigeria in order to be able to access these services. Not so much now. We can be able to offer this within the maternal center of excellence. Antenatal care, postnatal care, state-of-the-art delivery rooms. So you come in and you get treated with respect and dignity and love in a space whereby all the resources that you need, that women in UK, women in America can get without even giving two thoughts about it. They're going to be able to access this within here. We're going to have 3 surgical theaters. So anyone coming in for a cesarean section doesn't need to wait. We can have 2 or 3 going on at the same time with positive outcomes coming out from each of these theaters. And we have a special care baby unit now, but this will be upgraded to a neonatal intensive care unit. So we will be able to offer even higher level treatment for our sick neonates and sick babies. This, I mean, we talk about all these sort of services for the women, and what about the staff? They deserve something better. This is going to be a place where staff come, the future of Sierra Leone, that are going to help to change the maternal mortality ratio once and for all, are going to be trained in this place. They're going to receive all the sort of resources and training equipment from experts to be able to improve their skills, to be able to improve their knowledge base, so that they're going to go out from there, go forth and be able to treat others in other parts of the world. This is going to be like the flagship, the blueprint for Sierra Leone, to show that, hey, in Sierra Leone for many years, we've had this maternal mortality highest in the world. Hey, in here, we can also have the state-of-the-art hospital that can produce fantastic results, where people can come to, not just from within Sierra Leone, but for neighboring countries as well, to come and access this care. And this will be a rollout. I believe that this will just be the beginning, going to other parts within Sierra Leone, and together we're going to change this picture. Because these women, they deserve this. Our staff, our clinicians, they deserve this. They don't need to be seeing this on TV and telling me, I watch Chicago Hope. Hey, Chicago Hope can come to Sierra Leone too,
Yeah.
you know, and we can do this there. So this is
inspiring.
This is our dream. This is our dream.
That's so inspiring. Thank you so much for sharing that. Every time I get to talk with you, it feels like my heart grows 3 sizes. I know you inspire your team and you inspire us, and thank you. Thank you so much. I'm going to move now to Jourdan McGinn, the Deputy Executive Director of PIH in Sierra Leone. And since we've just been talking about Isata's beautiful vision for the Maternal Center of Excellence and how transformative this can be in Kono and beyond, because it can also be a blueprint. It's also a teaching hospital. I wonder if you can talk, Jourdan, about the origins of the idea for the Maternal Center of Excellence, what the planning process has looked like so far, and what the initial inspiration was.
Yeah, thanks, John. It's always hard to follow Isata and Joia in any kind of panel because they're such inspirational women. But I think in many ways, this Maternal Center of Excellence is really a product of the success that Isata spoke about. So, you know, because of the faith that people have gained in the health system, because of PIH's investments, we're seeing that more women are coming. And there's days when our beds are too few, and we've known for a long time we were going to run out of space. And so we wanted to think about how we expanded that space, but more than just figuring out how to get more space, we wanted to think a little bit more radically to say, you know, in one of the countries with the highest maternal mortality rates in the world, how could we radically reduce this? And so a group of us sat. It was almost exactly 3 years ago today. We sat in a small conference room, our midwife, our chief medical officer, myself, John Lasher, who is on the call, our executive director. And we asked ourselves, what would it take to accelerate the reduction of preventing these women of dying from causes they don't have to? What if we didn't just accept incremental progress? What if we didn't just add a few more beds? what if we rethought what was possible and we reimagined building really an entirely new ecosystem to address what, John, you said at the beginning, really is a crisis of maternal death. And so the MCOE is exactly that. It's a reimagining of what is possible for women in these poor and under-resourced communities like Kono District. And it's far more than a building. It's a part of this ecosystem that Joia talked about the community connecting to the clinics, connecting to the hospital. Mm-hmm. And it's about really changing that. So we've partnered with Build Health International. They're a longtime partner of PIH. Some of you on this call might know them. We worked with them with their brilliant work at the University Hospital in Mirabelais in Haiti. And now we're working with them to really design a 120-bed facility, which will triple the number of beds we have now on the existing campus of Koidu Government Hospital. And it's important that it's on this campus because this is a government hospital, and this Maternal Center of Excellence will be a government facility. It will be managed by the government of Sierra Leone. We've designed it with them from the beginning. The countless hours Isata and I have spent in the offices of our government counterparts, they sat with us as we were designing the building when Build Health International was here. And just today I was meeting with the minister about this. So really, this is a collaboration we're having with the government and talking about how we move this forward together as a flagship initiative, not just of PIH, but of the country of Sierra Leone.
Yeah, and I wonder if you can, I think that's really important, and it's just a super important part of this whole project is that, Partners in Health put partners first in the name for a reason. But I wonder if you can talk about the part of the MCOE and part of PIH's global mission to also be a teaching and learning organization, and how the MCOE has the potential to become a really essential part of the teaching and training of healthcare workers for the next generation.
Yeah, it's a good question. I mean, to start, I think we see the Maternal Center of Excellence really as the culmination of all of the work that PIH has pioneered across the globe in addressing women's health. We've been doing this for 35 years. And we want to take these innovations pioneered from our midwifery teams in Liberia, in Lesotho, in Haiti, in Rwanda, and we want to implement them collectively at this Maternal Center of Excellence. And really, we want it to be an innovation hub, a place where cutting-edge innovation in women's health are really pioneered, where they're tested and where they're replicated across Sierra Leone and across other countries where women's health continues to suffer unnecessarily. And as you said, John, we want the MCOE to be a teaching facility. And Isata spoke to this a bit. We want to train healthcare workers to be using the best practices of modern medicine, the kind of medicine you'd receive anywhere in the world. But equally, we want them to be social justice warriors. We want them to be champions in the fight for health equity. And you can't be what you don't see. And so we want them to envision what excellence looks like and have something to work towards, to push. And so we'll run specialist programs. Right now, if you want to become an OBGYN, you have to go abroad. So we want to train the first ever OBGYNs in Sierra Leone, nurses, midwives, health leaders. And I think this is really important because it's part of the multiplicative effect of the MCOE. These healthcare workers will train at the Maternal Center of Excellence, but they will go on across Sierra Leone to other hospitals, to other health clinics, and they'll deliver care to women and children. They'll deliver quality care, but they'll also deliver dignified care. As Isata was saying, they'll see their patients with love and with compassion and with dignity. And so we'll be building a movement beyond this facility. And so the world has been pioneering for decades, really, innovations in addressing the plight of women and children. And so if we can implement those in Sierra Leone, arguably one of the most dangerous places in the world to be a woman, and we can prove that it's possible to radically reduce preventable maternal deaths, we can prove that then it's really possible anywhere if we can do it here.
Yeah, and I think that's so important that it takes away the argument that, oh, it's too expensive, or oh, it's too difficult, or oh, it's too complicated, all of these arguments that have been used for decades to justify these profound injustices. I have to ask you a question about money, just briefly. I feel obligated to. What are the next steps when it comes to the MCOE? What is still needed? What is standing between the dream of the MCOE and the reality of the MCOE?
I mean, it's a good question. This has been 3 years of labor of love. I mean, the countless hours we spent, late nights, weekends, kind of working to make this a reality, and it feels close. We know how to do this in many places around the globe, and we're just in that last stretch. So we're currently slated to break ground in April of 2021. And we've raised about $18.5 million towards our fundraising goal of $25 million for this initiative. And just saying that out loud really just brings me so much joy to have had a community of people around the world who have faith that we can do this, who believe in this, and who have contributed with generosity and love to make it happen. So we're nearly there. We're really not that far from making this a reality. There's this last hurdle that we need to get over. But I feel a lot of hope about what is to come. And most importantly, I feel, as Isata said, that it's our role to make sure this happens, because these women really deserve nothing less. And I think we're really capable of proving that we can do this, and that women don't have to die of the things they're dying of right now. And we have the team and we have the community to do it. So we're very, very close.
Well, thank you, Jourdan. And that's really encouraging to hear. And thanks again for joining us. We're going to move now to talking with Armah Quist. Hi. Armah is a program officer at Lakka Government Hospital, which is the only dedicated tuberculosis hospital in Sierra Leone. I visited it last year, and what your team are accomplishing is amazing, or what your team is accomplishing. I don't have, that was bad grammar. I'm sorry. But Armah, you are also an activist and organizer outside of your work with PIH, and I know that you have a deeply personal story about your own experience while being pregnant with your daughter that you wanted to share. And so I just want to hand it over to you, I guess.
Okay, thank you, John. I'm so happy to share my experience on some of the barriers women face in accessing maternal health care. To start with, I work for Partners in Health in our multi-drug tuberculosis program, and I've been with the program since it started in Sierra Leone. On the side, in my free time, I run a feminist organization for young girls in Sierra Leone. So therefore, I considered myself a feminist. Being a teenage girl at age 19, I got pregnant and I was still in school. I was scared to tell my parents, so I was still in school, and they wouldn't accept me having gotten pregnant so young. I wasn't sure if the father of the baby was ready to have a child by then. I felt so alone. There was no one I could talk to. There was no support system. But eventually, my mom found out I was pregnant. She saw me vomiting in the morning, gained weight. By the time she noticed, I was already 4 to 5 months along the pregnancy. My mom talked to me and encouraged me to have a baby and they can support. I had to drop out of school once I began to show, as it was illegal by then in Sierra Leone to attend school while still pregnant. I was one of the best students in class, and it was heartbreaking to end my education while pregnant. Because of all of the stress, I developed high blood pressure during the pregnancy. That, coupled up with my young age, made me high risk for developing some complications. After my first scan, the doctors told me the baby was breech. I was terrified. I wouldn't survive the pregnancy, I thought. Yes, John.
And that must have been really, really frightening for you. Did you, at this point, did you go to a private healthcare facility? How did you proceed once that news came?
Oh, well, I went for prenatal care at the government hospital, some of the government hospital in Freetown, but 4 doctors refused to care for me because I was too high risk. Honestly, I was really high risk. They, like me, thought I wouldn't survive, so I eventually paid to get care at the private health facility. I didn't have insurance or any government's free health care services by then, so we had to pay in full for the visits. 1 week before my delivery date, I was admitted into the hospital as my blood pressure had spiked. I was very sick and slipped in and out of consciousness for a whole week. They tried to induce the labor but failed, and there was no genuine fear that I will not survive the pregnancy. Even in a private clinic, there was no critical care doctor, no emergency room specialist, and no life support machine. Eventually, I had an emergency cesarean section and delivered a healthy baby girl whom I named Andrina Lewis.
So after that extremely difficult experience and being in real fear for your life and for your baby's life, I'm sure, what did you do next?
Well, after surviving such a difficult pregnancy, I thought I'd be happy when she was born. That's what I thought. But I had lost all of my confidence. Having a baby at that age without a dad, having to return to school where everyone knew I was getting pregnant and being kicked out, it was so difficult to imagine my future. But after I delivered, I met a counselor at my local church who talked to me. She told me that you're not the first and you won't be the last. Forget about what people had to say and focus on yourself and your goals. She reminded me so much of my ambition, of the drive I had in school and of my potential. So I left the baby with my parents and returned back to the same school. I eventually graduated high school and went on to university. While I was in university, my parents, whom I was living with, moved out of the city into a more remote rural area surrounding the city. When we moved into our new neighborhood, I saw so many young girls who were so much like me. Some of them, I saw them and thought of what I wish I had when I was their age. Information which I lacked, support which was not there, love and care. I started by bringing them together on Saturdays morning. We talked about protection, family planning. We talked about how to keep yourself safe if you are active. We talk about struggles we faced as women. I helped them know their rights, that it was their body and their choice, and nobody should dictate to them what they should do with their body, and help them understand where they could get dignified care if they wanted family planning or had gynae issues they needed advice on. The goal was to create a safe space, which we accomplished, a space where girls can ask questions, where they can feel love and have support structure, which I never had.
Yeah, and I am so grateful to you for doing that work and for seeing when you saw people who were in a similar situation to you, or to the situation that you'd been in, you saw an opportunity to help them and you jumped at it, and it's really extraordinary the work that you've been able to do. And when we spoke previously, you mentioned that having put all of this work into building a feminist movement among young women in Sierra Leone, that you had so many hopes for the Maternal Center of Excellence, and that it was something that you so dearly wanted to see happen. I wonder if you could talk a little bit about what your hopes are for the MCOE.
Well, the Maternal Center of Excellence had a lot of potential to push women's rights in Sierra Leone, especially in Kano. This is exactly why the Maternal Center of Excellence needs to exist, because women and girls in Sierra Leone deserve better. They deserve a youth-friendly space. They can go and ask questions about their bodies and methods, a place I never had, but the Maternal Center of Excellence will. And if they get pregnant, they deserve to go to a hospital that will treat them with dignity, whether they are married or unmarried, whether they are young or old, whether they are rich or poor. They deserve a place where they have a good chance of surviving childbirth and never had to experience what I did on the verge of death. This is what the Maternal Center of Excellence will create for women and girls in Sierra Leone. It will create a place where the next generation of women can be empowered, where they, like so many girls I worked with, can realize their rights and full potential. The Maternal Center of Excellence is about far more than healthcare. It is about feminism, which I believe so much in, about women realizing their potential and about giving women the dignity and voice they've long deserved. Thank you, John.
Oh, thank you, Armah, and thank you so much for sharing that deeply personal and difficult story. I'm so glad that you're here with us. And I'm so grateful for all the work that you're doing. Thank you.
Thank you too.
So we're going to now see a very fancy, I don't want to overhype it, but I think it's quite fancy, fly-through video of what of the current designs for the MCOE, so that you can see what it will actually look like. And I think Jourdan is going to be our voiceover artist here, giving us a sense of some of the key design features and the materials and whatnot. So I will hand it over to Jourdan to voice over the video.
Thank you, John. A little bit of pressure. Great. So as you can see, this is the existing maternity center when we first came to Okono District back in 2014, 2015. And this, what you're seeing now, is really the future that we've been dreaming about. As you see here, this is the outpatient ward where women will get antenatal care, postnatal care, where they'll get family planning. This is what it will look like to drive into this facility, and really what will welcome you in terms of dignified care. You can see that we're aiming to use design features that promote the natural environment. Here is our neonatal intensive care unit that Isata spoke about. This will be one of our 3 surgical theaters, making sure that we can provide safe, high-quality C-sections. For women who are in labor, this will be the labor room before they go to deliver. And here will be the recovery room after they've delivered, so they can recover in a beautiful, dignified space. You'll see here that the MCOE is also about just creating spaces that women and their children and their families want to come to. So there will be beautiful green spaces, places where they can join together with their family members to celebrate, a happy new baby. And this is what the Maternal Center of Excellence will look like from kind of a big view. I do want to give a chance we have Jim and Sarah here, who is our incredible partner with Build Health International, and I want to give him a chance to kind of come in and share, because he's been so much of the vision and the partnership behind this. And Jim, I think you might be on mute.
Sorry. My second time with Zoom, only kidding. Thank you, Jourdan. This is really exciting for us to be participating in this. I first went to KGH in Sierra Leone in 2015 to support PIH during the Ebola crisis. And it's amazing the progress that's been made, but this project would be truly transformative. And we saw in Haiti what the Mirbelet Teaching Hospital has accomplished and leveraged, and we're just excited to to be able to use everything we learned through that process before, during, and after the hospital opened into this project, and we're very excited. So thank you all for making this possible. And happy to answer any questions about the design or the program. Thanks.
I'll ask a question if Jourdan doesn't want to. Jourdan, are you there? Oh, you're muted.
Yeah, it's all you, John.
Okay, I wanted to ask about one of the things that I've heard a lot of community response from is the use of stones cast off by the diamond mine that KGH and much of the city is literally in the shadow of. Can you talk about a little bit how that will be incorporated into the design, and also some materials that'll be used?
Sure, Jourdan, should I?
Yeah, go first, I'll follow you.
Okay. Yes, we're looking at incorporating cast off stone as part of the veneer of the building. And we are also trying to make the buildings as energy efficient as possible, because the cost of energy is very expensive in Sierra Leone. So, and it's, as anybody who's been there knows, is incredibly hot and humid. So wherever we can, we're using natural ventilation, passive ventilation, and also materials that'll help provide mass and insulation. And we're also trying to make the buildings very energy efficient, as well as welcoming and comfortable for patients. Jourdan?
Yeah, I mean, I think just to add to what Jim said, you know, BHI has brought in a really neat partner called the Living and Autodesk to use some analytics to look at how wind flows, precipitation, the way light moves, to optimize the design of the building so that the walls are facing a certain way. We can use natural light to help reduce the cost of overhead lighting. We can help promote natural circulation to cool temperatures, but also buying from the local economy. So figuring out, looking at kind of sustainably sourced timber from West Africa, supporting industry there. But as you asked, John, you know, the cascade of the building really being these stones that are the byproduct of the diamond mining process. And I think you couldn't really see it because it went fast at the beginning of the video, but there was this mountain behind the old photos of Koidu Government Hospital, and that is the largest diamond mine in West Africa. And for so many years, for so many people, it represented such horror and such tragedy. Kono was the epicenter of the decade-long civil war, and diamond mining, as Joia talked about, has been an industry of extraction. And so to repurpose this in something that represents hope, that represents life, to have people walk into a facility and see this stone and be reminded of optimism and transformation, I think is an incredibly powerful thing. So beyond all of these design features, I think that really is an incredible part of what we're trying to do, the symbolism of this reimagination.
That's just wonderful. And Jim, thank you so much for joining us and for all of your work on this project. It's the design y'all have built is really, really wonderful. So congratulations and thank you. And we're going to now welcome in all of the panelists. And I'm going to ask you some questions from our audience, if that's all right. Here everybody pops back up. So the first question is a rather obvious question, but it's one that we've gotten a lot of in various ways. And it's about COVID-19 and how COVID is affecting healthcare in Kono right now, and how COVID is also affecting the planning for the MCOE. So I'll just throw that one out there to all of y'all. But if nobody answers, I will call on you.
I'm looking at Isata.
I think I'll go for that one. So COVID, as far as healthcare in Kono, affecting healthcare in Kono, when it first started in March, April through to May, things were pretty bleak. People left the hospital in droves because they were scared. They thought that this was going to be a return of Ebola. They remembered those years and nobody wanted to be in the hospital, so they left. And what we then did was kind of went on the offensive. So right from once we started realizing that this was going to be big within Sierra Leone, worldwide, etc., we started going out, going and doing talk shows, going to the villages, going engaging the stakeholders, going out and meeting people where they were at and talking to them about, this is COVID. Yes, it definitely exists. And what we've seen and what we've heard in other countries, it does exist. But at the moment, we have time to prepare. It's not here yet. So there are things we can do to make sure that if and when we do get COVID, we're better prepared. So we made sure that we strengthened things within the hospital. We created an isolation unit. We created safe spaces. So when patients came in, we were able to move them along in a smooth and almost seamless line. We created a space within the maternity unit for pregnant women with suspected COVID symptoms so that they could be treated there away from the rest of the patients. And we went out there and we spoke to them and we persuaded them and we got them back. So we had a lull sort of through March, April, May, and then they started coming back. June, July, August, we're back to normal. We're back to people coming in and trusting us to be able to care for them safely. And yes, even within the hospital, the isolation unit and treatment center was within the hospital, but people come back through there and they walk past it, and we're trying to get things back to normal as much as possible. With regards to how did that affect the progress with the MCFA, fortunately, the PHI team came in February. So they were able to do all their groundwork and go back with that. So we had a lot of meetings. These people are my friends. We do a lot of Zoom calls. We do a lot. We talk a lot to each other. So we kept on planning. We didn't give up. We didn't give up. We made the progress, and we're pretty much on track. I'm quite sure. I mean, Jim can correct me on that one, but we did our work in the background, and we are where we should be, despite having gone through COVID.
And I think just to add to that too, COVID in some ways accelerated the need for this maternal center of excellence. It again showed weaknesses in the health system. And like Ebola, you know, we saw a 22% increase, as you said, John, of maternal mortality. And during the Ebola outbreak, and we knew we couldn't have this again during COVID, but also that health system investments were critical to not just preventing maternal deaths, but to making the system stronger as COVID continues to resurge. So, you know, we had an option of pausing and waiting this outbreak out, but, you know, the opposite was really necessary.
We also have a question from Leah, who writes, as someone who works in healthcare data and analytics, I'm curious about the IT infrastructure in place for collecting and analyzing data and what is being planned on that front. And I know that measuring outcomes is a kind of growing part of the work that PIH is doing. So I thought that might be a chance to answer both those questions.
Yeah, so I think I'll come in and then Isata, Joia, you can add anything else. So we've already started to introduce an electronic medical record system at the point of care. So it's actually done when you walk in the facility, very similar to what you experience in US health systems. So the MCOE will be fully digital. We'll do complete digital data capture. And what that will allow us to do is be able to have information about every patient from the moment they enter the facility through their decade-long care journey, from when they were adolescents coming to get, you know, sexual health education and family planning, to when they became mothers, to when they brought their children in for their immunizations. And so this will really provide us with information to help not only improve the quality of care, but to assess the impact. Alongside that, we're investing through an incredible initiative called the Impact Initiative, really in strengthening our data systems more broadly. So we're looking not just at facility level impact, but at population level impact. So we just did a baseline survey. We looked at kind of all of this, does the hospital have all of the stuff? What is the current utilization, but also what are patients' experiences? Why aren't they coming to the facility? What barriers are there? Not just in terms of road networks, but also, do they feel respected when they come? Are they getting care? And that's really helping to inform the design. So we'll repeat that survey, and we'll be able to see, you know, over the next 5+ years as the MCOE comes to fruition and our maternal health investments more broadly in the community and in the clinics come to life, what kind of impact those are having in a very quantitative way, both across population level impact and facility level impact. So we have some bold initiatives. I don't know, Joia or Isata, if you'd want to add anything. I also see John Lasher is here as well, our executive director in Sierra Leone. So if he wants to come in and add anything else.
Yeah, I can jump in for a minute. I'll just tie a couple threads together from some of the questions in the chat. On data, and I of course want to thank Charlotte Wagner and the Wagner Foundation for supporting this impact project that Jourdan is talking about, because we have always tried to do what is right. We haven't always been so good about documenting the impact, and we know that the impact of reducing maternal mortality is profound, and it goes way beyond saving a woman's life. It's also saving the baby's life and saving the other surviving children's lives. And so all of that we will be capturing, and even we're capturing now. I mean, any of you who know PIH know we're not waiting for a building to do the work. So we are looking with great anticipation to having a better space to work, but Isata and team have already done amazing work to reduce maternal mortality, and that work is just going to get better and better, and we're able to document that impact, and we'll be moving from paper records to digital. I also want to say, someone put in the chat about training, partnerships with Kenema and midwifery schools. I mean, I know that Isata has been working with the National Council of Midwives. The government of Sierra Leone is so excited about this project. You know, they feel that it's shameful to be the country that has the highest maternal mortality rate. They don't want that on their books. They don't want that for their people. And so they're excited to send trainees to a place just like the university hospital that Jim and all of his colleagues have beautifully built. You can't really train people in a terrible place with no supplies and a very undignified work environment and an undignified place to take care of patients. And so this Maternal Center of Excellence is going to be a great place for partnerships, and we're already having partnerships in Kenema and McKinney and with the Council of Midwives. And then lastly, I would say one of the advantages we have in Koidu, the city of Koidu, as we do in Mirebalais, is the roads aren't terrible. So there will be at least easy in and out for that particular facility. But transporting people from the very remote areas, the roads are terrible. And so one of the things that we will be doing as part of the Maternal Center of Excellence, as we said, no center for us is a building alone. It is the network of primary care centers, the network of community health centers. So we are doubling down on improving that referral network, as Isata was talking about. So there's a lot that goes into this work that's, you know, already in progress, but will be so much stronger with the center.
John, did you want to add anything?
No, well, first of all, just thank you all. I mean, it's an incredible panel, and it's been amazing to watch the team, especially those in Sierra Leone, kind of leading the charge. And Joia, you've been from the start a champion of this program, and so I just appreciate how far we've come. And I know many of you on this call have been hearing about the MCOE for quite some time. So just appreciate all of your support, and I'm looking forward to answering any questions. And yeah, just glad to be here, and nice to see you, John.
Nice to see you as well. We have a question just to go a little bit deeper into the transportation question, because it's both about staff and about patients. Are staff currently able to, most staff currently able to get to and from KGH or Wellbody fairly easily? And in terms of the outer, you know, so for context, for those who, there's the Wellbody Clinic, which is supported by PIH and which is just an incredibly effective health clinic. I mean, it's really what they've accomplished there is extraordinary. There hasn't been a single maternal death there in 4 years, I believe. It's incredible. But there are other primary health clinics in the Kono district that are not nearly as well supported, and in many cases are, you know, have almost no supplies, almost you know, very little support. So when thinking about like the transportation system, how much is that a consideration? And is it like Dr. Mukherjee was saying, where the whole thing has to get stronger together, and so the investment has to be in the entire kind of ring of the district?
If I could just jump in quickly and then hand it off to Joia, Jourdan, Isata, anyone who wants to speak. But what we've found, and Jim knows this particularly from the work at the University Hospital in Mirebalais, it's a sort of field of dreams. If you build it, they will come. Kono is not going to be the first place to get a paved road, right, around the rural areas, unless there's a beacon facility like a maternal center of excellence. And so not only will there be more roads, at least that's our aspiration, that's our hope, but we're hoping that the electricity will be spread out across the rural areas. Internet access will be increased. New businesses will pop up around the hospital. And so there's an economic advantage to building a hospital facility, even in a rural area, to spur economic development. Now, that's not the primary reason we're working on this project, but we know that we have to take the first step. That's kind of one of the first reasons why we're doing this. We know that there are any number of ways that we can spend a dollar in Sierra Leone. We could focus on building roads. We could focus on building a maternal center of excellence. We could focus on building out the primary healthcare system. But as you've said so eloquently and so succinctly, John, I can learn a lot from how succinctly you put our work. We have to do it all, but we're really good at helping to improve the health system. So training staff, building the facilities with partners like Jim and Build Health International. And I truly believe that the investments that will come as a result of us taking this first step in building the Maternal Center of Excellence, while we're simultaneously improving the public health units or the clinics around Kono District, that will incentivize other donors. It will incentivize the government of Sierra Leone to put more resources there. It will incentivize other partners to put more resources there. So whereas there may be 2 ambulances now going on dirt roads, 5 years from now, our hope is that there are 15 ambulances driving down paved roads. And so it's not going to be PIH alone, and it's not going to be the government of Sierra Leone alone. It's going to be a combined effort.
There have also been a few questions about from folks who are looking to better understand the size of the population that will be served by the MCOE and the current population there. What kind of I don't know what I know there's a word for it. I know there's like a medical word.
The catchment area. Yeah.
Thank you. I'll just stop the question there because you know what the rest of the question is. So what is the size of Kono, and what is the current? I believe like it's 550,000 people, and there are currently 40 maternal hospital beds.
Yeah, sort of. I mean, you have to put quotes around them as maternal hospital beds.
Yeah, absolutely.
And so I think, if you think about one of the issues, and Isata, Armah, and others, please jump in, but one of the issues around data, and this is, really how we have launched into this impact thing is, if you don't know where you're going, any road can take you there. That's Lewis Carroll. And I think there's this sense that we'll just deliver whoever shows up. But in fact, it's only the sickest women that even get to Koidu General Hospital, because most women are delivering at home and not well, right? And that's why the death rate is so high. So imagine, if you will, this is a community that the district is 550,000 people. That's roughly twice the size of just downtown Boston. I think downtown Boston is still like 250,000. And there's only one place that you can get a C-section. One.
Yeah,
that is just so absurd, right? So even as we're doing this, so I think when you think of the catchment area, this is the size of, a medium-sized American city that would have hospitals and clinics and operating rooms and maternity beds. And so the large majority of women never get to deliver in the facility. And it's not because they culturally don't want to. The facilities are not available for them. The beds are not available for them.
Yeah, I mean, the comparison that I often cite is that here in the north side of Indianapolis, there are also about 550,000 people, but we have 500 times more maternal hospital beds.
Yeah.
And that's pretty shocking. But if you go down the line, it's true again and again and again and again.
Tyler.
Hey,
yeah.
Dr.
Yo, hey, John, how are you?
I'm
hey,
good,
John,
man. How are you?
Good. Yeah, I just want to chime in and talk about the importance of also primary care development, because it's like, yeah, the Maternal Center of Excellence would be like a big achievement for the country, for Sierra Leone, and it will bring a lot of people, not only from Kono, but outside Kono, outside the whole country. But also like just developing like the primary care expansion project that we are doing now could also be a good process, because like just as you said, John, and when you visited and we visited Kumba, and you see how like a clinic that is not well supported, not well funded, how it operates. And so if we are able also to support those primary cares and they are able to deliver as well body is doing, and so you can receive mostly cases that require a C-section or require complicated deliveries that will come to the MCOE. That could also help, like in a way, as John Lasher said, like you can develop one component, but then a lot of development can come in. Like, for example, I remember when I read about Kolebo Hospital in Ghana when it was built. When Jerry Rollins wanted to build it way outside the city, people thought like he was crazy, but he said, just wait. When he built it, people started coming in, building like, and before you can remember, in 10 years, that place become a developed and a very huge city as compared to even the Accra itself. So it's just like developing one thing could create development from other things. Like as John Lasher said, you have businesses will come because of the MCOE. You have the government could also invest in electricity, in water, in roads. So to the MCOE, that could also bring a holistic or comprehensive development in Kono district. So I assume and presume that the MCOE is the first step, but it will also draw a lot of partners into Kono district to help develop and make it move as a very comprehensive project and developing the district, the whole Kono district. And also another thing is like, all the MCA is one, but also Kwedu Government Hospital will not leave it behind. We'll also develop it to become like a hospital that everyone can, as we've done right now, we can also develop it to be a hospital that people can rely on, can trust, can come to. As I said, when we started at KGH was empty. Nobody was going there. Now we're referring people from KGH to other hospitals in the country. While now it's the reverse. People are referring cases from the city and other places to KGH. So I think it's all like thinking that way, but like also as a comprehensive development could happen just because of the MCOE.
That's
Yeah,
great.
I think
great.
And I should belatedly introduce Dr. Byler-Berry, who is the founder of Well Body Clinic and great friend of PIH. And thank you so much for joining us. And I think that speaks again to the fact that so often we ask it to be either or when the answer is both and. And so often we say, well, resources are limited. And I've heard Paul Farmer say many times that yes, it's true that resources are limited, but they are less limited than they have ever been. And also, we all know that they aren't that limited. We all know. And we all know that we don't have to live in the world. We don't have to be choosing the world that we're choosing. We don't have to live in a world where 1 in 20 women can expect to die in pregnancy or childbirth simply because they live in an impoverished community. And knowing that we don't have to choose that world, I think, makes it easier to make the choices that we need to make to not live in that world. So I wish we had all night to answer questions. It is such a pleasure to talk with y'all and to learn with you. And I could do this until 3 o'clock in the morning if I had a couple beers, but alas, I have to turn it over to Sheila to close it out for the evening. But thank you all so much, and thanks for leading the way and showing us the way.
Thanks so much, John, and thanks to all of my colleagues from Sierra Leone and everywhere, and also great partners like Jim from Build Health International. You know, as you heard tonight, Sierra Leone has one of the worst maternal mortality rates in the entire world. And the reason why we want to build the Maternal Center of Excellence is we're already working, as you heard from the great speakers tonight, we're already working hard to address this at the primary care level, at the hospital level, but we really need to have better facilities. We need to be able to prove the point that we can make a difference. We can measure what we're doing. We can be a model, not just for Sierra Leone, but for the entire global community. So it really is a critical piece of bringing together our expertise in maternal mortality and caring for women and children around the world, from what we learned from Haiti and Rwanda and Liberia and many other places. The Maternal Center will be an embodiment, I think, of what can be done, and critical that we show that we will do it, and we will draw a line in the sand to say that maternal mortality is not inevitable. And it's critical that we as human beings all work to address this. You know, we're so grateful that we had a lot of families join us today, and a lot of you already know PIH and are well known to PIH, and we thank you for your generosity. If you want to hear more information about how you can help us, you know, work with women and children, not just in Sierra Leone, but around the world, please reach out to pih.org. We'll also be sending out information to all of you, and so you can follow the progress of this amazing work that's being done in Sierra Leone. As Joia said, Paul's book came out today, Fever, Feuds, and Diamonds, and it's really, I think, an amazing story of why PIH, what happened, what we saw when we went into Sierra Leone, and why we committed to staying long term. Also, The Bending the Arc is a documentary on Netflix, which tells the story of Partners in Health, and is really shows the history of where we've been, and I think shows us also where we can go in bending the arc next on maternal mortality, just as we've done with HIV and TB in the past. And there's also a podcast called Unchained, which John Lash actually was the host of, that talks about mental health in Sierra Leone, and also gives a great history, and you learn more about the country and amazing people that are there. So we thank you all for being here tonight, and thanks again to John and the entire family, and we really look forward to all being on this journey together and standing in solidarity to try to preventing maternal mortality and improving the lives of women and children everywhere. So thank you, and have a wonderful night.
Thank you. Thank you.